Yeah, so far we're really, we only started this last October, so we're just in the development stage. And again, I think working with CCACs and the OACCAC, we're looking at some models that would say, how might you experiment with this unique structure that the St. Joe system has brought together? I've been thoroughly impressed with the receptivity of CCACs to experiment, to try new modeling, to look at what the needs of the consumer really are, to ensure that they deliver on the mandate of government. So the government at the present time has said that ALC is a high priority, yes. And working with CCAC, we've seen in one of the LHINs we work in, it dropped from about 20+% down to about 14%.
Wow.
So some significant inroads. So I believe CCACs are quite uniquely poised to say, how might we use the system differently? And I'm not finding them overly boxed into a particular model. I think where government can help CCACs is to feel more comfortable in trusting them to use the money in the right way. So I would say fewer apron strings about how they use it, fewer rules about how many hours you can provide, and more autonomy that says, look, you have a global budget, you need to look after this population. How you do that, providing your markers and your measurement and your outcomes are good, we're going to back off in telling you you can only provide X hours a week or a month or a year. So that would be a direction I think would be.
So the solutions can be flexible to the patient population.
Absolutely. I think it has to be outcome based.
Right.
So I again push back on the concept that we should tell people how.
Right.
We should tell people what, and if they can't deliver, be thoughtful about, did we resource it appropriately? Was the infrastructure adequate? And if the answer to those things are yes, to the greatest degree we can, and they still don't deliver it, then I think you have to look at performance management and leadership and ask whether you have the right team in place.